All right. Hey everyone, welcome back to Patho-Mnemonic. Um, at this point, I presume you guys are familiar what this is all about, but for those of you who are new, this is an NBME Shelf Exam Step 2 CK content review series. Each episode is going to be tailored to the content of a specific shelf exam, and then obviously all of the shelf exams fit under the window of Step 2 CK. Um, in this episode, I will be going over some high yield stuff that came to mind when I was coming up with OB-GYN material to review. Um, Also, as for some suggestions that I got from previous episodes, I tried to include some practice like hypothetical multiple choice questions. So let me know how those work. But without further ado, we'll go ahead and get started. Um, so I'll start this episode off with talking about breast masses and like the algorithm for diagnosing them and working them up and managing them because I think that's pretty high yield. Um, It would be very weird if you take your OB-GYN shelf without encountering anything related to the breast, hence why we're talking about it here. Um, so let's say, for example, someone comes in and they have a small, circumscribed, non-tender, mobile breast mass. Um, Whenever you're presented with a breast mass, a general rule of thumb is to determine if it's benign or if it's malignant. And you can really make those differentiating features, or you can make that decision based on clinical features. And so these are features that are consistent with most likely a benign breast mass, like a fibroadenoma. This would probably be, or like fibrocystic changes. Contrast that with fixed, poorly defined. Maybe they have tenderness. They have skin changes, they have nipple changes, like nipple inversion is a common feature in these kinds of masses. These are likely malignant. So the next step in evaluation or management of anyone that comes in with a palpable mass, um, you want to do some kind of imaging. Even if you're like 100% convinced or confident that it's a benign breast mass, you still want to do imaging. So this is also where you get into like what kind of imaging based on the age. This is another really high yield detail to know for shelves and step, and obviously in clinical practice. Um, if they're younger than 30 years old, you want to get an ultrasound. If they're older than 40 years old, you want to get a mammogram. And the way that I remember like differentiating between ultrasound and mammogram is the younger a woman is, the more dense their breast tissue is. And the increased breast tissue density can kind of not make the images as pretty for a mammogram. So you want to get an ultrasound. And then if they're in that weird 30 to 40 years old window, you can kind of like make a decision about either getting an ultrasound or a mammogram, um, based on, how the patient presents to you. There's no like wrong answer. Um, But if, let's say, they're like 35 and you get an ultrasound and it's negative, but you're still concerned for a mass, you would consider getting the other imaging modality. And this just reiterates what I said earlier, that anytime anyone comes in with a suspected um, breast mass, like a palpable mass on physical exam, you want to get imaging of some kind. Just because like I've come across questions where I'm reading it and it's like, a small, well-circumscribed, non-tender mobile breast mass. And I'm like, this is most definitely a fibroadenoma. Like they're going to be fine, no big deal. You still want to get imaging. You don't reassure. Let's say, for example, maybe they have a mass, maybe they don't. They come in and their concern is that they have like green, white, maybe it's like brown or sticky breast discharge. Once again, anytime you're presented with like off-colored um, breast discharge, you want to think about whether or not this is a benign or a malignant condition. So if it's like this color or if it's like sticky, it's most likely benign. Let's say someone comes in and they have red, which means it's bloody, breast discharge. Again, you think, is this benign or malignant? This is most likely malignant. So anytime it's like bloody, immediately red flag should be going off. Like there is some sort of a malignancy going on. Um, Common cause of bloody discharge. This is another just kind of like one-off fact that NBME shelves and STEP like to ask is like, what is the most common cause or which is the most likely diagnosis for someone with bloody breast discharge? It's an intraductal papilloma. The next steps in management or evaluation of benign or pathologic breast discharge, again, is imaging. So if they're younger than 30, you want to consider getting an ultrasound. Um, if they're older than 40, get a mammogram. Very similar to a breast mass. If 30 to 40, you consider either. If the first is negative, you want to do the other one. Um, you might also see, like, let's say, for example, you get both an ultrasound and a mammogram, and they're both negative, but they still have discharge, like they still have bloody discharge. You want to get an MRI because that's like the most sensitive, or not most sensitive, but that's like the next step if both of these are negative. Um, and this is kind of like the algorithm, specifically like if I have bloody breast discharge, like if you're concerned for malignancy, you would want to get this sort of an evaluation. One other thing that I'll mention here is you can have like a prolactinoma, which is not necessarily a breast malignancy, but it can present with like galactorrhea. So like if a woman who like did not recently give birth or is not breastfeeding all of a sudden starts producing milk, in that case, you would want to start thinking, well, there's some sort of a um, like an endocrine abnormality that's causing her to start producing milk for like no reason. And one of those causes could be a prolactinoma. But like, that you would want to consider that versus someone who comes in with like this benign breast discharge. So just keep your head on a swivel for that. Okay. Continuing on breast masses, let's say, for example, someone comes in and they have not only do they have a palpable breast mass, but it's fluctuant. Like you can feel like, it's a little flexible. You can kind of feel like what might be fluid in there. As we said before, anytime they have a breast mass, you want to do imaging, so ultrasound or mammography, and then plus or minus MRI, but ultrasound and or mammography based on our algorithm. And then you aspirate, because obviously there's a mass and there's fluid in it. You want to take the fluid out. And then based on your next steps are really informed by what happens to the mass after you aspirate it. So if you aspirate the mass and the mass resolves, you reassure the patient and you reevaluate in like 4 to 6 weeks. If the mass persists, like, let's say, for example, you do an ultrasound, you see a mass, you see a fluid collection, you aspirate the fluid collection, you do a repeat ultrasound, and there's still like a mass there, you would want to consider a biopsy because this could be a malignancy. If the drainage is bloody or drainage or the aspirate, whatever, you stick the needle in and you pull out the fluid and it's bloody, you want to get a biopsy. So just like bloody discharge, if the fluid inside of this fluctuant mass is bloody, you want a biopsy. If the mass recurs, so let's say for example they have this cyst or whatever fluctuant mass, they come in, you aspirate it, and then you send them on their way and they come back and the the fluctuant mass is still there. You repeat the aspiration and then what I was seeing on like the AAFP and recommendations from ACOG, you repeat the aspiration, but then you consider a biopsy if it recurs again. So that's like if they come back for if this is like fluid-filled collection number 3, then you would want to consider a biopsy. That's what I was seeing. I'm not as confident with this criteria, but ultimately the bigger thing to keep in mind is like if the mass is recurring, your like sensitivity or your threshold for suspecting malignancy should be increasing. Um, so let's say, for example, you have a patient that had this breast mass and then you get a biopsy and it's confirmed, like the biopsy confirms breast cancer. Um, your management is based on like where the mass is. So let's say, for example, you have a mass in like the upper outer quadrant of like one breast. In that case, you do a lumpectomy, you take the lump out, And then you consider a sentinel lymph node biopsy to see if there's any spread into the lymph nodes. And then plus minus consider radiation therapy to that area to prevent recurrence. Um, Deep to the areola or diffusely throughout the breast, you want to get a mastectomy or take the whole breast out, which basically is like, you can't pick one quadrant to take out without leaving residual cancer behind. So you just take the whole thing out. Okay. So this is our first like practice multiple choice question. I'll just read it out for you. There's a 30-year-old postpartum prima gravida, and her chief complaint is breast pain and engorgement. Over the past day, she's had chills and malaise. She's been trying to breastfeed, but she says it's painful and she struggles to get the baby to latch. You get a set of vitals. She has a temperature of 38 Celsius or 100.4 Fahrenheit, heart rate of 86, blood pressure of 110 over 73, respiratory rate of 18. You do a physical exam on her and you find focal, firm erythematous swelling of the right breast. And then, which of the following is the next best step in the management of this patient? Is it A, dicloxacillin therapy, B, ultrasound of the right breast, C, incision and drainage, D, reassurance, or E, mammography? So I'll give you a couple seconds to think about that. Okay, the correct answer for this is you want to start them on dicloxacillin. So this is lactational mastitis. So I highlighted, like if I was taking a shelf or step exam, um, these are like the features that I would highlight. So they're 30 years old, they're recently postpartum, they have breast pain and engorgement, chills and malaise, they have a fever, they have focal firm erythematous swelling of the right breast. So it's unilateral. It doesn't say that there's a fluctuant, well, it doesn't say that there's a palpable mass, and it also doesn't say that there's fluctuance. Um, so looking at the options that I provided here, since there's no palpable mass, you don't need to consider imaging. So you don't need to consider an ultrasound. You don't need to consider mammography. You can further rule out mammography because she's 30. So you would, it's kind of like at that weird like 30 years old versus if she's in the window 30 to 40, but she's like closer to the 30-year-old demographic. So she's too young for mammography. Um, so, based on the clinical features, it's most consistent with lactational mastitis, and the first line therapy for lactational mastitis is dicloxacillin. Um, but then going over the other answer choices, ultrasound of the right breast, like I said before, there's no palpable mass. So you don't need to get an ultrasound or any kind of imaging. You can also diagnose lactational mastitis clinically, like you don't need any other evaluation. Um, Incision and drainage. There's no palpable fluctuant mass on physical exam to suggest something like an abscess. And incision and drainage is like the first line therapy or like management. That's like the first thing that you would want to do for someone who has an abscess. So the way that a breast abscess would present would be very similar to this, but like on physical exam, it would say like physical exam discloses a firm um, focal like fluctuant mass of the right breast, whereas this is just swelling. Um, Reassurance. This would be more if the patient had come in with something like a galactocele, which is just like a milk, kind of like a clogged milk duct per se, um, causing like milk buildup in the ducts, and then you have like a mass. Um, But also, like if a galactocele is presenting with like a palpable fluctuant mass, you would not want to reassure them. You'd want to consider getting imaging. So this answer is wrong for those reasons. And then, like I said, for mammography, the history and physical are less consistent with breast cancer because she's like febrile and she has this erythematous swelling postpartum. So it's like more likely that this whatever uh, palpable thing is going on in her breast is mastitis as opposed to like an actual mass from malignancy. Um, you could also think like fat necrosis is another thing, like a benign condition that could cause breast masses. But again, there's no mass in this question, so you don't need to think about fat necrosis. Okay. Changing gears a little bit to another high yield thing that shows up on OB/GYN exams are the physiologic changes of pregnancy. And so these the best way that I could present this like visually is to just make a table and then to show the parameters and their associated changes. But really the way that I keep all of this stuff in mind is because all of these changes are related to each other in some way, shape, or form. And it's related to the fact that mom has to basically provide life for not just herself, but also this growing baby. So just going down this list, cardiac output increases in pregnancy because mom has to not just provide blood and like circulation for herself, but she also has to circulate the placenta. Um, so cardiac output increases. While I'm on the topic of the placenta, another thing that shows up, like a physiologic relationship with the placenta, is placenta is pretty much like a new organ that develops during pregnancy. And it's kind of like added in parallel to the other organs. So it's like another route for blood to flow through, which like reduces the overall resistance of the circulatory system. Um, all of that is to say, because there's this like new organ that's been added to mom's circulatory system, cardiac output has to increase to kind of compensate. And another thing that you'll see is glomerular filtration rate. That also increases during pregnancy, in part because the cardiac output is increasing, right? Because since more blood is circulating through the circulatory system, more blood is also flowing through the kidneys. Therefore, more blood is flowing through the glomeruli, and that increases the glomerular filtration rate. This increase in glomerular filtration rate can cause glycosuria. So, like if, I don't know, a question shows up and it's like, so, pregnant woman comes in for like a prenatal screening test or not test, like a visit, and or something like that, and it just almost like incidentally she gets a urine sample and there's like some glucose in her urine, and she has like no history of diabetes, no history of like gestational diabetes. It's just because there's an increase in GFR. In one of my future episodes, I'll talk about like gestational diabetes, and all that fun stuff. But for here, I'll just allude to it for now. Um, Another thing that changes during pregnancy is pH, or like the acid base balance in mom. The pH increases, which means that there's an alkalosis. She's alkalotic, and then of course you have to think like, well, is this alkalosis respiratory? Is it metabolic? Is it mixed? All that other fun stuff. Um, in this case, it's likely or mostly a respiratory alkalosis, and that's because tidal volume increases. So tidal volume increases because mom is breathing for two, is kind of how I remember it. Um, and because tidal volume is increasing, minute ventilation increases, right? Minute ventilation is tidal volume times respiratory rate. Tidal volume is like the really big driver in this case. So minute ventilation is increasing. And because minute ventilation is increasing, mom is breathing off more carbon dioxide. So her serum carbon dioxide, the PCO2, decreases. And the way that I can remember that is because like not only is she breathing off her carbon dioxide, but she's also breathing off the carbon dioxide that the baby is producing. Um, so all of these, like the pH, the tidal volume, the PCO2, all of them are related. She has a respiratory alkalosis because her tidal volume is increased because she's breathing for two, and because her tidal volume is increasing, her PCO2 is dropping, which causes the respiratory alkalosis. Um, Her plasma volume, mom's plasma volume increases during pregnancy, and the extent to which the plasma volume increases, or the rate at which the plasma volume increases, how do I want to present this? Actually, I'll get to that in a second. Plasma volume increases during pregnancy, and then kind of like a trick question that shows up is, um, like a pregnant mother might come in and it's like somehow you're concerned for like an anemia because their hemoglobin or their hematocrit are low. That's usually fine. It's like a physiologic anemia of pregnancy. And the plasma volume and the hemoglobin are related. And this is because in pregnancy, plasma volume increases and hemoglobin and hematocrit, like mom is producing more red blood cells, but the rate and the extent to which plasma volume increases is greater than the compensation in hemoglobin. So there's like both plasma volume and hemoglobin are increasing, but plasma volume is increasing more. Um, and so there's kind of like a dilutional physiologic anemia of pregnancy. Okay, so that pretty much ties this up. But again, like all of this kind of ties back to you can like memorize this whole list, but it gets so much easier when you kind of like make connections between all of them because it's, like a sequence as opposed to just like fact one, two, three, four, five, six. Okay. Um, Another high yield thing that comes up on OB/GYN questions are fetal heart rate tracings. Um, Usually, like they'll show you a diagram of the fetal heart rate tracing. Sometimes they will just describe what the findings on the heart rate tracings are. Um, but in any case, these are some pretty good questions to go over. Um, so we have a prima gravida at 37 weeks gestation. She presents to labor and delivery in labor. Her pregnancy was uncomplicated. Rupture of membranes produced clear fluid. Vitals are within normal limits. Her fetal heart rate tracing is shown, and then which of the following is the next best step in management? Um, I don't want to like verbally explain what is on the fetal heart rate tracing because I think it'll give the answer away. Um, but for those of you who are like watching the video, take a look at the fetal heart rate tracing, and then I will go over the answer choices. Is it A, reassurance? B, do you do an immediate C-section? C, do you do an amnio infusion? Or D, do you do maternal repositioning? Okay, the answer to this one is maternal repositioning. So this fetal heart rate tracing is showing recurrent variable or is showing variable decelerations. Um, and this like the etiology of variable decelerations um, is after rupture of membranes, amniotic fluid kind of like helps keep the baby buoyant in utero. And so it's like the baby, but there's also the umbilical cord in the amniotic sac. But like once you lose those fluids, you lose the fluid cushion. Um, and so sometimes the baby will like press up against the umbilical cord, and that increases systemic vascular resistance. And so um, if you remember the equation for mean arterial pressure equals cardiac output times systemic vascular resistance. Whenever there's cord compression, systemic vascular resistance like shoots through the roof. And then in order to compensate and keep mean arterial pressure the same, the cardiac output has to go down. And if you remember, cardiac output equals stroke volume times heart rate. The lever that is pulled to compensate with cardiac output is heart rate. So the heart rate goes down because of this increase in systemic vascular resistance. And because the heart rate is going down, that shows up on the fetal heart rate tracing as this deceleration. Um, so the management of someone that has, or of a baby that has variable decelerations, the first thing that you want to do is like do maternal repositioning. So like the left lateral decubitus position, just to kind of like, yeah, if the cord is being compressed, you want to reposition the mom so the cord is no longer compressed. And then that should bring the heart rate back up. Let's say, for example, you try maternal repositioning and you still see these variable decelerations, then you would want to consider giving an amnio infusion. Um, because if at that point you want to give some more like cushioning to prevent cord compression from happening. Um, if it's like a really, really bad, like you've tried repositioning, you've tried amnio infusion, and you still see like a bunch of variable decelerations, and it's looking like the baby is not tolerating labor, then you would want to consider doing a C-section. But you don't, based like if you're just seeing these decelerations and you haven't started like maternal repositioning or any of these less invasive maneuvers, um, you would want to start with this first before going straight to C-section. Um, that's all I want to talk about for this one for now. We're going to go over some like more specific examples and like explain how to go through fetal heart rate tracing, but this was just to introduce the concept. Okay, so when you're looking at a fetal heart rate tracing, you want to see if it's in a normal range. So the normal fetal heart rate range is 110 to 160 beats per minute. Um, and we'll like we'll see this on um, some example heart traits, fetal heart rate tracing is coming up. One other thing that will show up, like let's say for example, there's the baby has a heart rate that's like baseline is at like 180 or something. The most common cause of fetal tachycardia is maternal fever. So mom is sick and then baby's heart rate goes up. That's just a high yield um, association. And then probably like one of the most famous mnemonics for fetal heart rate tracings is the veal chop mnemonic because it's like veal is the type of uh, morphology that you'll see on a fetal heart rate tracing, and then chop is like what it actually means. So we'll go through each one and then we'll like summarize at the end. But if they have variable decelerations, that's cord compression, which we saw on the first practice question. One other important kind of thing to help you narrow down a differential to see like, is this a variable deceleration or is this something else? Variable decelerations are quick. They're quick on, they're quick off. So if it's like, if the baby's heart rate is fine and then they have a deceleration and the deceleration um, is less than, like if the duration from onset to nadir is less than 30 seconds, that's consistent with a variable deceleration. Onset obviously is like when the deceleration starts, and then nadir is like the lowest point in the decel before it comes back. Um, Moving on to the E in veal chop is early decelerations. This is consistent with head compression. And we'll see an example of early decels and head. We'll see an example of all of these coming up soon, but just showing the mnemonic now. Um, if they have A cells or accelerations, not decels, that's okay. Baby's fine. No need to worry. Um, One other parameter that's important to remember for accelerations is if there's an increase in 15 beats per minute for at least 15 seconds, um, that's like consistent with an acceleration. And then if mom comes in for a non-stress test, um, it's like reassuring heart tones or reassuring heart rate tracings. If these accelerations happen at least two times in over the course of a 20-minute period. So the way that I remember it is it's like increase in 15 for 15, twice in 20 is consistent with like a good acceleration pattern on fetal heart rate tracings. And then the last letter is a late decel, which is consistent with with placental insufficiency. So it's like if the baby isn't getting enough blood or like not getting good enough blood supply from the placenta, um, that's like what placental insufficiency is basically. And then that'll show as a late deceleration. So just to recap this mnemonic, veal is like variable decel, early decel, acel, late decel, and then chop is what each of those letters in veal correspond to. So cord compression, head compression, okay, and then placental insufficiency. Okay, so as I promised, these are some examples of fetal heart rate tracings. We'll just go through each one. So this one we already saw. This was the variable decel, and if you look, this one is not as good. I like this one. So here's pretty much the onset, and then each of these boxes is 10 seconds. So it starts here, and then like 10 seconds later, it's at the nadir. So 10 seconds later, it's at the lowest point, which is like 90 beats per minute. So less than 30 seconds. So it's consistent with a variable decel, and then it comes back up to baseline. So that's a variable decel. And then this morphology down here, this is like maternal uterine contraction. So like here's the resting tone, and then there's a contraction here, and then it comes back down. Um, So that's another thing to kind of look at on fetal heart rate tracings. If we take a closer look at the baseline, so without all of this like decel action going on, if you look at this baseline, it's right like 140, which is in the 110 to 160 range. So a good heart rate tracing, well, a good baseline because it's in the 110 to 160 baseline, and then you just have these variable decels. Another thing that you want to look at is like how the changes in fetal heart rate are associated with uterine contractions. So I'll circle back to this one in particular as we see the other ones coming up, but I'll plant that seed because we're going to go on to this one, which is an early deceleration. Um, so here's like the baseline, which looks, let's see, our baseline is about 151, yeah, 150s or so. So fine, no tachycardia, no bradycardia. Um, and then you want to look at the onset, you want to look at the nadir, you want to look at the end. So the onset's like right here, they point out, and then it's like 10, 20. Okay. And then here's the end, here's the onset, 10 or so, here's the end. Um, so, you have this morphology of the deceleration, and then what I do is I like come down here and then I try and synchronize the um, the timing of the decelerations to uterine contractions. So here's the uterine contraction. It's like resting tone, and then it starts. Mom starts having contractions. She builds it up, and then it's at the max point here, and then it comes back down. So it's like this wave pattern. If you draw a line from the top or the nadir of the uterine contraction, and then you correspond it to the fetal heart rate tracing, you'll see that this deceleration happens ahead of the uterine contraction. So it's early, hence an early deceleration. So it's like happening um, like in the race, so to speak, between like the heart rate and the uterine contraction. This one is like ahead. So if it's an early deceleration based on the morphology and like how it synchronizes with the uterine contraction tone, if it's early, that's consistent. As we said on veal chop, an early deceleration is consistent with head compression, which is just like, because mom is contracting, you have contraction or compression of the head, and then that increases the um, SVR, and then cardiac output decreases to compensate. Very similar to variable deceleration, except instead of the cord being compressed, it's the head. And then another way to remember early deceleration is, I mean, not just veal chop, but, like I said, the deceleration happens ahead of the uterine contraction. So another way to remember it. Okay. So we'll move on from that to this fetal heart rate tracing. I wish I could find a better, like a higher definition picture, but I think this still does the job. This one is a little bit harder to find a baseline, but I just kind of like look at the whole thing and then kind of like on a vibes-based assessment, kind of determine a baseline. It looks to be about here, which is like what, 120, 130, 140 or so. Again, fine, no tachycardia, no bradycardia. But then you have these like spikes that go up to what, 160 or so. This isn't really a good picture, but it's the best I could find. Um, so we'll look at this one right here. Like there's an increase to, I'll say like 150. It would be more convincing if it was like up to 160 and then like held there for a little bit and then came back down to its baseline. But if you look at the uterine tone, it's resting. Like there's no contractions happening at all. They're just like the baby all of a sudden has an increase in heart rate. Um, and that is an acceleration, an increase in heart rate, an acceleration of the heart rate. That's an acceleration. And then remember that increase in 15 for 15, twice in 20, whenever you're doing a non-stress test. All right, so we will look at this fetal heart rate tracing. Um, Again, we'll look at the baseline without all of these like weird decelerations and stuff. If we're looking at the baseline, it's pretty consistent with a heart rate of 130, which again is fine. No tachycardia, no bradycardia. Um, and then you have these decels, which are happening pretty regularly. And then, so you see these decels, and then you come down and you look at the uterine tone. So here we have the onset of a deceleration. And if we draw a line down to the uterine tone or the uterine contractions, this deceleration starts when the uterine contraction is at its peak. So it's late. And then it reaches its peak after the uterine contractions have like subsided. And then it happens again at this next contraction, right? The contraction is at its peak, but the baseline or the heart rate doesn't start decreasing until later. And then it happens again and again. So these are late decels, self-explanatory. The mom is contracting and then the decelerations are late. Um, so, you know, contrast that with early deceleration where they're happening ahead of time. Late decelerations is where they're happening after or they're delayed. And that is placental insufficiency. Um, okay, so before I go on to these ones, like I said, I'll come back to the variable decels because sometimes you'll look at a fetal heart rate tracing and you'll be confused because you'll see the heart rate tracing and you'll be like, well, it could be variable, but it could also be like an early decel or a late decel. You know, I can't really tell. I mean, if you just looked straight up at this fetal heart rate tracing, you could make the argument that it's like, I mean, you could make the case that it's a late deceleration because it's like, well, the peak on this one is like right a little after the peak of the uterine contraction. But if you remember, like, yes, the peak of this variable decel is technically after the nadir of the uterine contraction for both of these variable decels. Um, and it's also hard because you don't see any decelerations that are happening just like on their own. Because sometimes what you like a slam dunk diagnosis for a variable deceleration is if you're looking at a fetal heart rate tracing and the uterine or the contractions aren't happening. Like there's no contraction. There was just like all of a sudden just some random deceleration. So like if you had a deceleration here where there's no contraction going on, then you're like, this is a variable decel, easy. But like these are only happening with contractions. And so you're like, well, you know, what is it? Is it a variable decel or is it a late decel? But if you come over here and look at the late decel, the contraction or the decel doesn't start happening until after the contraction has reached its peak. So that's like very convincing of a late decel versus this variable deceleration where the nadir of the decel is like right after the uterine contraction reaches its nadir. And then again, you want to look at like um, the onset to the nadir of the variable decel, like that less than 30 seconds. Um, and this is like what, 10 seconds? So that's consistent with the criteria for a decel or a variable decel. And then if you look at the late decel, it's like the onset's right here, 10, 20, 30-ish. So you can like look at the number criteria and you can be like, well, maybe it's a late decel. But again, just like look at the severity and like the relationship of the decels to the uterine tone. And then if it's more consistent with a late decel, then it's probably a late decel versus a variable decel. Um, but at the end of the day, the best way to, oh no, don't look at that. The best way to make to like differentiate between these two is to just practice and look at a lot of fetal heart rate tracings. Hopefully you didn't see I accidentally scrolled too far and revealed the answer for this one, but it's pretty self-explanatory either way. No significant A cells or D cells on this one. So then you're like, well, you know, why is this being shown? Well, let's look at the baseline. It's hanging out at about 180. So here's 160 down here. Here's 180. And it's just chilling there at 180, even like with contractions and stuff. So this is getting at fetal tachycardia. So the baseline heart rate is 180. And then what's the association with fetal tachycardia? Maternal infection or maternal fever. Okay. I didn't mention this one in veal chop or before now because I honestly think the best way to learn this is to just look at it. This is not a bunch of, I mean, yes, technically speaking, it's like a bunch of increases and decreases in heart rate, but it's this like sinusoidal fetal heart rate tracing. And it's like, you know, no changes are happening with uterine contractions. This like sinusoidal fetal heart rate tracing pattern is fetal anemia. So this could be like in the setting of hemolysis in the baby, or like hydrops fetalis, maybe. Um, in either case, this is bad. Like you need to get this baby out sooner rather than later. Off the top of my head, I don't think this is an indication for like C-section. I'll have to look into that and then I'll like hopefully close the loop in a future episode. In either case, If you see a fetal heart rate tracing and it's showing fetal anemia, it's bad. And there's like something pathologic going on. Okay. That ties up fetal heart rate tracings, at least for now, in this episode. So we will move on to another vignette. Um, I put question marks up here because I didn't want to spoil what this is. Um, so a young prima gravida at 34 weeks gestation age is brought to her friend to the emergency department with complaints of a severe headache that started 4 hours ago. She was resting at home when the headache began. She has tried acetaminophen without relief. She endorses persistent blind spots in her vision. She also complains of right upper quadrant pain and has vomited once. You do a set of vitals, and her temperature is 37.5, heart rate 96, blood pressure 141 over 92, respiratory rate is 20. Visual field testing confirms blind spots. The right upper quadrant is tender to palpation, and then which of the following is the most likely diagnosis? Is it A, acute cholecystitis? Is it B, migraine with aura? Is it C, preeclampsia? Is it D, preeclampsia with severe features? Or is it E, eclampsia? So I'll give you like a couple seconds to think this through. Young, prima gravida, 34 weeks gestation, severe headache, no relief with acetaminophen. She has blind spots, right upper quadrant pain, right upper quadrant tenderness. All right, this is preeclampsia with severe features. Um, so again, like the high yield features that I'll go over here. She's young, she's prima gravid, 34 weeks gestation. We'll get at that in a sec. She has a severe headache that's not responsive to acetaminophen. She has blind spots, right upper quadrant pain. She's afebrile, which like rules out cholecystitis or any infectious etiology. Um, and her blood pressure is 141. So she's hypertensive. And then she has right upper quadrant tenderness. So um, we will go through, each of these answers and like knock out the wrong ones. So acute cholecystitis, like I said, she's afebrile. And then right upper quadrant pain and right upper quadrant tenderness is also a feature of severe preeclampsia. And we'll get into like the diagnostic criteria, but just so you know now, right upper quadrant pain is not immediately acute cholecystitis. One other thing that I'll mention with like right upper quadrant pain and cholecystitis, especially in a a pregnant woman, is when the uterus is growing, it displaces a lot of stuff in the abdominal cavity. So if a woman comes in and she has like or right upper quadrant pain, or like maybe right mid, or actually no, it's quadrant, or like right middle side tenderness or pain, and she's febrile. You also want to consider appendicitis, just because the appendix normally is in the right lower quadrant. That's where like the pain happens. But in pregnancy, especially later on in pregnancy, the appendix gets like displaced and it gets pushed up. So um, keep appendicitis on the differential as well. Anyway, in this case, she's afebrile, so you don't want to think acute cholecystitis. Migraine with aura. I kind of like tried to trick you with a migraine with aura because it's like or like blind spots and then a headache and it's really bad, nausea and vomiting. Um, Specifically, another thing that can kind of lead you in the direction of preeclampsia with severe features is she has this headache without relief with acetaminophen, and she's also hypertensive and has right upper quadrant tenderness. So all of these features together sum up to be more consistent with preeclampsia with severe features, as opposed to like coincidentally she has hypertension and also she has cholecystitis and also had a migraine with aura. Because all these features together are like all arrows that point towards preeclampsia with severe features. So then how do you differentiate between preeclampsia and preeclampsia with severe features? Um, we will go over the specific criteria for like the blood pressure stuff for preeclampsia and preeclampsia with severe features and stuff, but um, her blood pressure technically meets the criteria for preeclampsia, but she has a lot of these other quote unquote end organ dysfunction features that suggest severe features. So I won't try to explain it right now because I have a slide coming up that explains everything. Obviously, preeclampsia with severe features is the right answer. And then among the most severe hypertensive disorders of pregnancy is eclampsia. And you rule this out because she has not had a seizure. If a woman has like preeclampsia and has a seizure, immediately that's eclampsia. I think the diagnosis changes. Um, I think I also say this coming up soon, but you can also have a patient, like if a pregnant patient has a seizure and you rule out any other cause of the seizure, let's say she has like she's normotensive and she has a seizure and you rule out every other cause of a seizure, that can still be eclampsia. Like you don't have to be hypertensive to diagnose eclampsia if you've ruled out other causes of a seizure. But that's coming up. So this is a very busy slide that has like all of the differentiating features of hypertensive disorders of pregnancy. This is like extraordinarily high yield, not just for shelves and step, but also for clinical practice. The magic number for differentiating between, well, I'll just go through this. So it's like from least severe, quote unquote, to the most severe is like you start with chronic hypertension, which is just like essential or like primary hypertension, just like, someone who's not pregnant. So if someone has hypertension before 20 weeks of gestation, that's chronic hypertension. And then the specific criteria for chronic hypertension are listed here. So if it's elevated 120 to 129 over 80, and then you have like different stages. The most important thing I'll say is where you get into hypertensive urgency, which is at least 120 over, what am I saying? At least systolic, at least 180, and or diastolic blood pressure at least 120. 180 over 120. It's very complicated. I don't know why I couldn't explain it like that. Um, the numbers are here. You can see them. Um, anyway, you also want to differentiate between a hypertensive urgency, which is just this blood pressure, and a hypertensive emergency. And it's basically like a hypertensive urgency becomes an emergency when there is end organ damage, like they have a seizure or a stroke, kidney failure, heart attack, so on and so forth. Um, there's a chance that this could come up on an OB-GYN shelf question just to kind of like see if you can differentiate between chronic hypertension and like preeclampsia. Um, the difference between chronic hypertension and gestational hypertension is gestational type hypertension you can only diagnose after 20 weeks of gestation. And then the blood pressure criteria are at least 140 over 90. So that's like the magic cutoff. Then you get into the realm of preeclampsia stuff. So the way that I think of preeclampsia is gestational hypertension and at least one of the following additional features. So everything starts with gestational hypertension. So it's like after 20 weeks of gestation, if you check that box, then good, or I guess not good if it's preeclampsia. Um, and then you check the other box if it's like the blood pressure is at least 140 over 90, and or I should say. Um, So you have at least one. So you have gestational hypertension, you meet these criteria, and then you have proteinuria, um, which is urine protein over creatinine ratio, at least three, or a 24-hour protein urea content of at least 300 mg per deciliter. And the way that I remember this is three eclampsia. So like the ratio is three or 300, three eclampsia. You can also make a diagnosis of preeclampsia if they have the other, features could be like thrombocytopenia less than 100, pulmonary edema, if their liver function tests are up to two times the um, limits of upper limits of normal. And this could also be like baseline, like if a woman has like baseline liver disease and her LFTs at baseline are elevated, um, you want to like you'll make the diagnosis of preeclampsia if it's like up to two times her baseline. Um, so that's that. And then if they have neurologic deficits, like they start having a headache or they have a stroke, blind spots, altered mental status, clonus, things like that. Um, and then you shift over into diagnosing severe preeclampsia or preeclampsia with severe features. Um, if they have like if their blood pressure is at least 160 over 110, that's just like you diagnose preeclampsia with severe features. Or you can make the diagnosis of preeclampsia or preeclampsia with severe features if they have preeclampsia and at least one of the following features of end organ damage. So neurologic problems, like we saw in the vignette, headache not responsive to acetaminophen, and you exclude other causes. Um, or if they have vision changes, and then if they have liver problems or liver and organ damage. So you see like elevated LFTs, thrombocytopenia, because the liver produces thrombopoietin, um, right upper quadrant pain or epigastric pain that's unresponsive to meds, and then you also exclude other diagnoses. Um, or if you have creatinine that's at least 1.1 mgs per deciliter, and or you have a doubling of serum creatinine without other disease. So like if their baseline is whatever and then it like doubles, then that's like consistent with severe or preeclampsia with severe features, or if they have pulmonary edema. So here I'll make a pause and like iterate or like reiterate that it can be kind of confusing to make a difference between preeclampsia and preeclampsia with severe features. Um, Usually, like the way that I approach this kind of stuff is if they're like if they have gestational hypertension and they have this proteinuria and like that's it, then I'm more likely to think that this is preeclampsia. But really, once they start showing these like end organ damage stuff, like we saw in the vignette to introduce this, then that's what leads me down the road of picking severe preeclampsia. I know it's like, if you look at up to date, there's like a table that lists these other features associated with preeclampsia. And you're like, well, these are also consistent with preeclampsia with severe features. Yeah, it's confusing, but the the clinical gestalt is more like as you're reading through the vignette, you'll like those features usually tip me more towards making the diagnosis of preeclampsia with severe features. But I will say that patient in the previous vignette, her blood pressure didn't meet the criteria for severe preeclampsia because she had like 141 over 92 or something. She wasn't at that 160 over 110, but she had like a lot of these other end organ damage problems, which was why it's severe preeclampsia and not just preeclampsia. Um, I also put like the abbreviations for the different kinds of preeclampsia and like hypertension, just because like that's how they'll show up on the wards. So just to kind of like figure out what you're looking at, because OB-GYN loves their abbreviations. So PEC, preeclampsia, SPEC, preeclampsia with severe features. You'll also see like SI-PEC, which is just preeclampsia in someone that has um, that shouldn't be gestational. It should be chronic. So if like a pregnant woman has chronic hypertension and then she develops preeclampsia, that's superimposed preeclampsia or the SI. Let's say, for example, um, the pregnant mother has chronic hypertension and then develops preeclampsia with severe features. That's usually, at least I've seen it written as SIPEC with SF or superimposed preeclampsia with severe features. And then, as I said before, eclampsia is if they have a seizure. It does not require hypertension at presentation if other causes of the seizure are excluded. That's just like important to know. And then you also have HELP, which is hemolysis, elevated liver enzymes, and low platelets. And these usually show up on like lab test results. So if they have any evidence of this stuff, then you make the diagnosis of HELP. I don't have, at least in this presentation, I don't have like a vignette for HELP syndrome, but I'll say this now. If you make the diagnosis of HELP syndrome in a pregnant woman, you need to like deliver the baby immediately. Um, because not only does the name of the syndrome say what it is, hemolysis, elevated liver enzymes, and low platelets, but it's also like you need to help the mom and help the baby, which is just like you need to deliver them because it's bad. Um, you might not get a question on, you may or may not get a question on like the etiology of preeclampsia, but it all kind of comes from abnormal placentation, which leads to endothelial dysfunction and systemic vasoconstriction. So it's like, you don't really have good spiral arteries, and you have like really weird modeling of the placenta. And so mom's like circulatory system is like, I need to help this placenta, and it's like not good. So, it tries to perfuse it by causing systemic vasoconstriction to like, keep blood going to the placenta. So, that can cause hypertension. And then you have like endothelial dysfunction, which can cause all of this end organ damage stuff. But it ultimately boils down to this. I think we're almost done. This episode ended up being significantly longer than I thought it would be. Um, This is the same vignette, except the question is now, which of the following is the next best step in management? So we made the diagnosis of preeclampsia with severe features. Which of the following is the next best step in management? A, betamethasone and induction of labor. B, immediate C-section. C, hydralazine. Or D, expectant management. I'm just going to show the answer in the interest of time. You want to do betamethasone and induction of labor. Um, because what I was seeing on like UpToDate and ACOG guidelines and things like that is if they're like beyond this 34 weeks gestational age window and they have preeclampsia with severe features, you want to induce it and get the baby out to help both the mom and help the baby. So based on those criteria, you rule out expectant management. But we'll just go through these answers. So betamethasone, you usually give that. Well, it helps the mom and it helps the baby specifically as well. So you can give betamethasone to a laboring mother up to 37 weeks of gestational age. And the reason why you give betamethasone is because it facilitates surfactant production in a premature newborn, and that prevents respiratory distress syndrome in the newborn. This isn't the PEDS shelf, so you don't need to know RDS, but check out my PEDS episode. I don't think I've talked about RDS yet, but it's coming. Don't worry. Um, anyway, so you induce labor. Um, you'll also see like immediate C-section. You do not like preeclampsia with severe features by itself is not an indication for C-section by itself. So, like, if there's other stuff that's going on that's showing you that the baby is not doing well, then you would want to think about doing a C-section. But severe preeclampsia by itself is not an indication for immediate C-section. Um, Hydralazine, like, if mom has gestational hypertension or chronic hypertension, yeah, you could probably give hydralazine. But there's a better option here being induction of labor, because severe preeclampsia at least 34 weeks of gestation indicates delivery. Um, this also brings up the mnemonic for like the good blood pressure meds to give during pregnancy. Those being um, hydralazine, labetalol, methyldopa, nifedipine. Um, and the way that I remember that, you could like hypertensive moms love nifedipine. That one works. I remember he loves my neonate, which shows my bias towards peds. Um, but either case, he hydralazine loves labetalol, my methyldopa, neonate, nifedipine. So those are those. Um, Expectant management, you obviously want to do something because they have severe preeclampsia and they meet the criteria to deliver the baby. Okay. I think this is the last slide I have, and then this episode is done. Um, okay. Another high yield thing regarding preeclampsia are the risk factors for preeclampsia. And the list is very extensive and it's a bunch of stuff. And I came up with a mnemonic to remember it, and I will just show it to you here. Okay. So the most important risk factor for preeclampsia is a prior history of preeclampsia. And that's consistent with like a bunch of pathologies in OB/GYN, is if they've had a past history of the condition, they're at an increased risk of having it again. And that applies to preeclampsia as well. It also applies if they've had a family history of preeclampsia. If they have renal disease, so like lupus, diabetes, chronic hypertension, so on and so forth. If they are at extremes of maternal age, so if they're really, really young or if they're really, really old, that's a risk factor for preeclampsia. If they have chronic hypertension, um, that's a risk factor. If they have a long time between pregnancies, that's another risk factor for preeclampsia. If they have autoimmunity, that's a risk factor for preeclampsia. And then if they have multiple gestations, like twins or triplets, that's a risk factor for preeclampsia. Um, there are probably some other additional risk factors. These are like the most important ones, or the ones that I remember. And the way that I remember this list is preeclampsia, but I couldn't find any other letters for like the remaining ones. But at least it gets at the first part. So Preclam or preclam for the risk factors. And then you'll want to know the complications of preeclampsia, those being premature birth, right? Because like the previous vignette was like she has preeclampsia with severe features and that like you need to deliver the baby. So premature birth is a complication. Um, Placental abruption is another factor or another complication of preeclampsia. If you think about like the abnormal placentation, um, fetal hypoxia leading to small for gestational age birth is a complication of preeclampsia. Preeclampsia can also cause hypercoagulability, which can lead to a stroke in preeclampsia. Um, you can also have DIC in preeclampsia, or disseminated intravascular coagulation or coagulopathy. Um, you'll also see like third spacing, which is like edema in like bad spots. So you can have like stretching of the liver capsule, which causes the right upper quadrant pain in preeclampsia, specifically preeclampsia with severe features. And then you can have pulmonary edema, just kind of similar to the third spacing because fluid gets pushed out into the alveoli. And then this kind of complications of preeclampsia kind of are real life manifestations, I guess, or presentations of the etiology of preeclampsia, that being the abnormal placentation leading to endothelial dysfunction and organ damage, systemic vasoconstriction, right? Because if it's abnormal placentation, it messes with the mom's circulation because mom's circulation is like, I need to provide blood to this placenta, but the placenta is messed up. So like, you need to do all these compensations and it makes mom really sick. But because there's also bad blood flow going to the placenta, it's also bad blood flow going to the baby. So you can have like fetal hypoxia leading to small for gestational age and stuff like that. Okay. I thought this episode was going to be so much shorter than it actually ended up being. But that's it for this one. Again, as always, thank you for your patience and thank you for sticking with me to the end. If you made it all the way to the end, I really appreciate it. Um, As always, feel free to leave me suggestions or comments if there's like a specific topic or a specific like style that you want me to try out in future episodes. Very receptive to helping you guys out as much as possible, making this as accessible as possible. So, with that being said, thank you again. If you are studying for your OB-GYN shelf, good luck studying for your OB-GYN shelf. If you're studying for Step 2 CK, good luck studying for Step 2 CK. And if you're on your rotations, have fun on your rotations and see a bunch of interesting stuff. Okay, I will be done and I'll give you guys the rest of your time. Thank you.